For those of you interested in academic genealogy and who were here last session, we talked a little bit about how our first speaker, Vikrant Baz at Dartmouth, was my academic sibling, and that he was just taking on Ishu, a new PhD student who had been one of our CHEPS master's students, which makes him sort of my uncle and my nephew at the same time, I think. Dayo has a very similar history and kind of connects into this crazy CHEPS family in that I first met him when he was working as a sort of postdoc visiting scientist with Jeff Parker. So I got to see the very early stages of his career and follow his work as it started developing in energy, and then eventually as it began to evolve into healthcare. And so his mentor, Jeff Parker, is now at Dartmouth with Vikrant, and therefore will be teaching Ishu, which makes us, I think, next door neighbor, sibling cousins of some academic sort. So I want to welcome you to the CHEPS family that you are already so connected with in such a strange way. And with that, I'm going to turn off my screen share and allow you to take over. And again, welcome and thank you for spending some time with us.
Thank you. Let me get to share my screen just for a second here. Share this. Do you see my slides?
Yeah, we see them.
Good. I'm going to project them in a second to make sure it's full screen. Okay, it should be full screen now. Okay, do I have to admit people that are coming in? Okay, okay, I'll close that. Okay.
No, I'll do that, yeah.
Okay, let me get started. First and foremost, let me thank Elizabeth, Ms. Fisher. Thank you so much for organizing my invitation. You know, Elizabeth's emails just come in at the right time. I'm like, oh, Liz from UMich, I better respond. And as Professor Amy Cohn said, we've known each other now for probably a decade through Jeff Parker from my stint at Tulane University. So I have an interesting trajectory. I have a bachelor's degree in electrical engineering from a university in Nigeria. And then I moved over to the American University in Cairo, where I did my master's in industrial engineering. And then I started my PhD at the University of Waterloo in Canada before in systems design engineering. They call it systems design engineering, which in those days was a department by itself, but now has moved underneath the electrical and computer engineering department at the University of Waterloo in Canada. So I started my PhD there, then felt if Canada, was this good, the US must be far, far better. Then I left Canada, transitioned to University of Massachusetts, where I completed my PhD in industrial engineering and operations research about a decade ago. So that's a very short history about my academic experience. I also have some industrial experience. I worked for Heineken beverage manufacturing company in Nigeria as an automation engineer. But today I'm gonna talk to you about a topic that, was a topic that came out of circumstance. In other words, it wasn't my intent to actually dabble into healthcare. But, when I was in the School of Business at Tulane, there was no demand to look for funding for research, to look for funding for grad students. Then when I transitioned to the School of Engineering, it became a major challenge. You have to bring in the funding. And at that point, I felt, I have the resources, I have the toolkit to address a variety of problems. Why should I stay in my training, which is energy systems and optimization, when actually I can also address some of the health challenges we have out there? And that's what gave birth to this project, which was funded by LMI. LMI is a top government organization, consult for government agencies on different topics. So LMI is at the intersection of research organizations like universities and government agencies like the GSA, Department of Energy, Department of Homeland Security. So they collect all these projects, invite the academic partners, compete for funding to address some of the problems. And one of the problems was this particular problem, which actually started out as a problem on malaria vaccine supply chain, the supply chain of malaria vaccine, which even as we're talking right now, does not fully exist. So we're trying to look at what would happen to existing supply chains should there be a new vaccine, especially in least developed countries. That's what led to this topic, improving vaccine access, optimizing storage and hub location in a developing country. So by way of introduction, I'll tell you a little bit about my research lab, what I do for 9 to 5, and what I do 5 till 9 the following day. It's a it's a 24-hour cycle for the academic. We don't have a break. Okay. Then I'll talk about the motivation and the statement of need for this problem. I'll then dive into the methodology, and I'll explain some of the results we have and some of the concluding remarks, which are also very relevant in this COVID economy. Okay, so by way of what I do, my research group, I call it SysMOLED. SysMOLED, that's Systems Modeling Laboratory for Economic Decisions. In my lab, I have about 4 PhD students right now. I have graduated 3 PhD students. I have a number of master's degree students and even many more undergrad students in my lab. And I also have quite a number of high school students. In fact, I just got an email from one just before this meeting started. So we have quite a number of people associated and affiliated with what I do, which is captured in this infomercial here. I teach mainly engineering economics, time value of money, making decisions between, okay, upfront capital investment is high, what justifies such an investment over the life cycle of the asset, for example. How do you make choices? Then I look at energy health policy. I use the toolkit of optimization modeling to address energy choices under conditions of uncertainty, health policy when we're faced with a catastrophe such as this pandemic. Then I also investigate system interdependence. In other words, if a catastrophe strikes, maybe a hurricane strikes, a location, what are the interdependent sectors of the economy that also suffer the ripple effect of such a disaster? How do we provide or develop resilient infrastructure systems that will withstand such disasters? And as you can tell, the proof of the eating of the pudding is in the eating, broadening participation. You notice that there is a very, very small number of underrepresented minorities, especially in the STEM fields. And I've been looking at ways by which we can enhance that pipeline. So some of these themes have also been funded by the National Science Foundation, Department of Energy, foundations such as the Sloan Foundation. And the tools I use, as you can see on the right-hand side of the slide, is I use General Algebraic Modeling System, GAMS, for optimization models. I use Visual Basic for applications in Excel, VBA, and just Excel itself. You'll be amazed at the power behind using Excel for analysis. Okay, I use MATLAB, Stata, microeconomics, and in addition, we've been using some R programming, a little bit of Python here and there, depending on the need and the question to be addressed. In terms of my current research, this 5 is just a snapshot of about maybe 15 of research projects going on. And I'm projecting this 5 because they are heavily well-funded. For example, resilience and interdependence, we're looking at the food, energy, and water nexus. And we're studying the Columbia River Basin in the US. Our counterparts in China are studying the Mekong River Basin. If there is dryness or there is drought along the river basin, what is the effect and consequences of that on food, agricultural production, on energy production? How do we ameliorate such drought? So this was an NSF infused program. They call it Innovation at the Nexus of Food, Energy, and Water Systems. In collaboration with about 4 colleagues, collaborators, we got $500,000 on the US side to execute this project. On the China side, they got 3 million renminbi, which is equivalent of $500,000 as well to execute this project. Technology management and policy is something funded by the Department of Energy, where we're generating synthetic time histories of wind energy in an integrated energy system framework. It's a lot of statistical analysis. Right now, what we're developing is, it's not like we're developing it new, but we're conditioning it for wind energy. We call it umbrella sampling. So we're looking at sampling from multiple distributions at the same time in order to target the tails of the distribution. When you look at integrated energy systems, the tails of the distribution is where the significant effect of the volatilities are felt. In an NSF career, which I got last year, NSF Career Award, $500,000, I proposed something out of the blues. I said, hey, when you break your hand heals. How does that take place? Can we learn from how biological systems react and how cells recombine in what we call morphogenesis? It's got a lot of partial differential equations. Can we learn from that process in creating a resilient energy infrastructure system, democratizing energy access? This was funded by the Arthur P. Sloan Foundation for about $250,000. We're looking at community solar projects, service learning for innovation. This last bullet just came in last week. This is the $300,000 funding, where we're beginning to look at, can we expand the engagement? Can we deepen the engagement of engineering students by engaging them in service learning, innovation culture? Can that engage them even deeper? That's what we have in terms of our research echo. There are so many other projects, but in the interest of time, I'll get to today's talk. And today's talk, I start this by showing us what I call the scourge of polio. The scourge, if you know what a scourge is like something that whips you. We've been whipped across the world by polio over several centuries until the early 60s, 1960s, when the world decided to do something about eradicating polio. Polio is one of those infant mortality diseases that the world has done a lot to eradicate. When you look at this map of the world, you see that Africa is predominantly colored yellow, showing that, you know, it's polio-free, but then it's not certified to be polio-free. And more importantly, look at the countries in red. Those countries, especially the one in Africa, that's Nigeria. And by the way, I'm from Nigeria. That's my country right there, showing that there's still prevalence of polio. And this was as at 2017. And you can see those other countries in Asia. That's Pakistan and what's the other country that the US is fighting wars at? Basically, those are the countries where the incidences are still predominantly high as at 2017. What you see here is a recent news article that came out just late August, showing that Africa has eradicated wild polio virus. One other thing you're going to find is that Nigeria, that we're looking at as the red country, okay, is no longer endemic. And this was as at August 25, 2020. So it's important to understand the context from which this exercise is coming from. But before we got to where we are today, what were the strategies put in place? What actually led to the country being a laggard when other countries were performing much better and advanced? For example, less than 50% of children had full schedule of basic vaccines. Okay, we talk about the 5 or 6 infant mortality vaccines that children are expected to get while they are kids before the age of 5. Less than 50% in a country that has almost 200 million people. Nigeria's overall immunization rate, even as of today, hovers around 70% of the population. So the country lags significantly in terms of vaccine logistics. The map you are looking at here is one of the states, one of the most populous states in the country. We call it Kano, K-A-N-O, Kano State. In 2010, in 2011, 2012, what you see over the progression of those 2-3 years is that the incidence of the diphtheria cases is worsening across those years. Okay, the redder, the worse off the state becomes. The divisions you see across in the state are the local government areas within that state. So what we're saying here is, are we bringing in enough vaccines to maximize coverage? When you talk to Gavi, the Global Alliance for Vaccination and Immunization, they tell you, yeah, we ship millions of doses to Nigeria. We ship millions of doses to this country. So what's going on? Is our supply chain strong enough to ensure all facilities are covered with the right frequency? You know what we say about supply chains? A supply chain is as strong as its weakest link. In other words, once you have a broken link anywhere, that is where the strength of that supply chain ends. So there's a significant opportunity for impact and making decisions that will advance the system. So there's a problem of inadequacy, which is exacerbated by uncertainty in demand, and we see literature that shows that supply chains are strained in many least developed countries due to limited infrastructure, and that has been placing lives at risk. Government-run vaccine supply chains are limited in many facets. How to maintain vaccine quality throughout the supply chain. So vaccines come into the country in excellent health condition, But we're talking about a country where electricity is a luxury, okay? If you flip on the light here and the light comes on, but in that environment, it is a luxury. It comes on when you're asleep or when you don't need it. So the question here is, how do we ensure vaccine availability at service delivery points? These are the limitations of government-run supply chains. How do we keep pace with new policies and technologies in the management of these vaccines? 3 themes define supply chain issues in least developed countries. 1, structure. In terms of structure, are we talking about a centralized system or a decentralized system? Strategy, the monitoring and reporting processes. How structured are they? How systematic is the chain of reporting? And when you combine the failure of structure with the failure of strategy, it just makes for a cocktail of risk, failure of supplies reaching the intended targets. Why country choice? Why Nigeria? When you look at this map that shows the Logistics Performance Index, a score that is generated by UNCTAD, United Nations Conference for Trade and Development, the Logistics Performance Score measures how well a country performs in terms of its logistics. Here you see on the horizontal axis is the log normal of the GDP of the countries in question against the score of their LPI, their Logistics Performance Index. What you find here is rich countries are at the top end of the line, okay? Top right corner, and the poor countries are at the bottom left corner. There is a linear trend that shows that how wealthy a country is in terms of its GDP. It's also a reflection of how well the country performs in terms of its Logistics Performance Index. Now, we identify 2 countries here, which ordinarily, when you compare a country like Nigeria with the Netherlands, okay, the GDP of both countries are about the same. Now, of course, if I look at GDP per capita will probably show a different insight. But here we're just looking at raw GDP numbers. Nigeria is way below the Netherlands in terms of logistics performance indicator. So at this point, we said, how do we address this problem? By looking at the vaccine supply chain in Nigeria. Well, one of the things we had to do was looking at incorporating uncertainties to estimate vaccine delivery performance. There's a mismatch, or what I call variability, in the pushed quantities. You know, this is a country where ordinarily you expect demand to precede supply, but in this case, quantities coming from abroad and they are pushed down. They are pushed down to those that need the vaccines. So we're using the proxy as a proxy for demand, the quantities that are supplied. There's a shortfall in delivery due to limitations in cold chain capacities. We just talked about limited electricity supply in the country. What method did we apply? We developed a model of multi-echelon supply chain network. We implemented stochastic optimization because of the variabilities I mentioned up there, and we introduced supply chain performance metrics that we're going to see how they perform. As a background, Nigeria is the most populated country in Africa, okay? Almost 200 million people. Now, if you look at the area, it's almost 1 million square kilometers. That's approximately 2.5 times the size of California. So imagine packing such number of people in such a small space. So it's a very densely populated country. It also operates a 3-tier system of government: the federal government, the states, there are 36 of those states, and you have the local government areas, 774 of those local government areas, and the federal capital territory, where the capital of the country is, which is similar to if you were to compare with Washington, D.C., for example. So if that gives us a flavor of what the country is, let's see what it looks like in terms of its topological representation. Here is the map of the country. In the middle is the federal capital territory. This color-coded map shows the zones that the country has been zoned into. So when vaccines come from the Switzerland, from abroad, they go straight to the Federal Capital Territory. From the Federal Capital Territory, they go to 6 zones. The 6 zonal hubs are represented by the states with the underline. So for example, from the Federal Capital Territory to Kano, to Bauchi, to Lagos, to Enugu, to Delta, those are the hubs currently in the country. Then from those hubs, the hubs serve the states that are color-coded, as we have seen. So you can begin to think about this network as the manufacturer is abroad, sent to Abuja, which is the National Strategic Cold Storage, this Federal Capital Territory in the center of the country. From there, it goes to 6 zones, okay, the 6 hubs. And from the hubs, it goes to the states. Then from the states, it goes down to the health facilities. So you can see that this is a multi-echelon problem. What we have tried to do here is capture this multi-echelon supply chain. The other or vaccine supply logistics flow diagram shows that we have the National Primary Healthcare Development Agency, which is the agency that administers vaccine control in the entire country, goes through the National Strategic Cold Storage. From there, it goes to the Zonal Cold Strategic Storage, to the State Cold Storage, then to the local government or local county storage before it gets to the health facilities, showing that failure on any of this can lead to a collapse of the system. Now, what we did was we captured the system in a classic supply chain environment where we say that we have an order up to policy. So we have the capacity of the chain, maximum capacity, over which over time the quantity gets depleted. There's a lead time I have imposed in the system such that once the lead time elapses, replenishments come and we order up to capacity. You can think of it as an SS policy. It declines again over time and then it gets replenished. But if life were straightforward, there will be no problems. The problem here is that in some instances, before the replenishment comes, there are back-ordered quantities that are not satisfied, such that by the time the replenishments come, they may not even satisfy the back orders, and yet there are new requirements on ground. So what you find is a cascading of the back orders. So what we have done here is we said, how do we address these back ordered problems? How do we address this cascading? We then put a distribution on these cascading back order problems, and we decided to estimate the capacities that will be needed to accommodate as much of the vaccines as required. Now, the best solution to this problem is have infinite capacity supply chain. In other words, every regional hub should have infinite storage capacities, but we know that is impossible because it costs money. That's why in our analysis, we took the independent demand to be log normally distributed based on data. We allowed back orders to be met, and we allow those based on the next receipt of vaccines, on the doses of vaccines, and we allow others from regions to the central storage, as from the central storage from the manufacturer. Lead time, we assume to be known because we know when the vaccines come into the country. What are the variables in the model? So we have time T for the period. I designates the region. Q subscript IT is the ordered quantity by region I from the central storage. KT is the ordered quantity from the manufacturer by the central storage. Beginning inventory at each region, BIQ. Beginning inventory at the central storage, BIK, EIQ, ending inventory at the central storage. We have shipment to region I at a given time from the central storage. We have shipment to central storage from the manufacturer. We have shipment in the pipeline on the way to the central storage. And we have the demand, which is very volatile because in Nigeria, there are instances where when it gets to counting people even count animals as humans when it's time for census, because the higher the population, the more resources they tend to get. So what we see here is we see that there is a randomness in the quantities that are shipped, and then we define the parameters we just saw in terms of the beginning inventory as a function of shipped from to the regions in the previous period plus what ended the previous inventory. The beginning inventory in the central storage is also following the same, but based on the sum of all that was shipped out in the previous period, plus what is coming in the pipeline, plus what ended the previous inventory. The QIT, which in this case is the quantity we're trying to make up to for each of the locations, follows theta I, where theta I is the region's other up to quantity. That is our decision variable. Here we're asking how large should the capacity be for the storage of the vaccine in this location. Okay. Likewise, we're looking at the shipment to the regions, which in this case depends on if we have enough quantity to ship, then every region gets as much as they have requested for. If there's not enough, then we do a sort of division where we divide, we allocate based on the amount you have asked for relative to the amount that is available. That is the otherwise condition we have here. And then the same system applies at the central capacity, the central storage location, where we're trying to determine how large should the national strategic cold storage be? How large should it be to accommodate all these variabilities in demand in the system? One of the most important parameters here is the back-ordered quantity, which is a function of the variable demand if the beginning inventory at each of the regions is less than or equal to 0, or it could be the difference between the variable demand in case demand is very high and the beginning inventory in each of the locations. That differential is back ordered, or it could be 0, in which case there is no back ordered quantity. What we then try to do is, I said earlier that we can build a system where the facility is so large that we can store as much doses of vaccine as possible. But we know that is not possible in the sense that it's going to cost money, maintenance, and all the bells and whistles that come with maintaining vaccines of such high volume. The objective then is to minimize the average vaccine inventory in the system while simultaneously meeting requirements. So on the one hand, we're saying with the left side of our mouth that we want to minimize capacity. On the other side of our mouth, we want to satisfy the demand in the system. How do we capture that? Well, we minimize the total quantity of vaccine at any point in time, both based on the beginning at the central location, BIK, the quantity in the pipeline, PT, and the sum of all beginning inventories at the regional hubs. We take the sum of all that over time and we average out per time. That's why we're dividing by T. We're minimizing this quantity subject to the choice of theta I and phi, where theta I represents the quantity of the capacity in each of the regions, and phi represents the capacity in the central storage. Well, you don't see phi and theta I, but they are intrinsic to the variables we have in the model, subject to a very strong constraint here. Here we're saying that the fill rate should be less than the herd immunity threshold. The herd immunity threshold is simply a threshold that says that if out of 100 people, we vaccinate 67 of them, then the remaining 33 don't need to worry about vaccination. That is a threshold for which everybody is safe. Here we're saying the fill rate, is it less than the herd immunity threshold? And what is the level of failure of that probability that's captured by delta? So we're saying that if the fill rate does not satisfy the herd immunity threshold, by how much is that not happening? Meaning that the higher the delta in this equation is, the worse off the system is. The lower the delta, the better off the system is. We also put bounds on the capacity constraints of each of the locations and the central capacity, the central location. The fill rate, if you look at this equation right here, the fill rate is a function of back-ordered quantity. In this case, if back-ordered quantity were 0, that numerator, if it's 0, then the fill rate is 100%, meaning that we're satisfying demand as it is needed. However, if there are back order quantities over time, then the fill rate goes lower than 100%. This is a very strong check. Now, what we're looking at here are the values of delta we experimented with. In fact, when we started the analysis, we said on average, the country has about 80% performance threshold. 80% captured by the 20% failure rate here, we said, how much more capacity would we need if the country were to improve to 95% efficiency, which is the 5% we have here? Well, what did we do? We collected data over 4 years, spanning 2011, 2012, 13, and 14, for which data was available. I actually traveled specifically to get this data. Very hard to get data. Spent 2 weeks looking all over the country for data, which eventually came weeks after I had left the country. Anyway, this shows the value or the quantities, number of doses of vaccines that were shipped based on vaccine type and to each of the 6 regional locations I showed earlier. These are the quantities. Based on these quantities, we're able to estimate an underlying distribution for each of the vaccines, because the vaccines also have their own characteristics. Those characteristics are what we captured based on the figure you're looking at. So in terms of the supply, we see that we have a skewed representation, which was why we modeled the demand as a log normal distribution. The skewness informs the choice of the distribution we use. So now what did we do? We ran the model by looking at the impact of improving the system from 80% fill rate over to 95% fill rate. This graph is saying a lot of things. I scale it down a little bit to show the actual optimal result. What we see here in the bars are the quantities of capacity in terms of the storage that is needed in order to achieve that improved performance in the system from 80% to 95%. The yellow dots show the increase in quantity that we need at the central storage where the vaccines first get into the country. This is on the condition that we are keeping the status quo. However, if we decide to look at improving the system in terms of rearranging, I'll show that in a second. But one thing we see here is that empirically, the supply chain performance improvement and uncertainty mitigation require expansion. No doubt about that. We need expanded suite of capacities. It's not a one-size-fits-all solution because different vaccines vary in terms of how they perform across the regions. The problem is exacerbated at the lower echelon of the chain, the last mile problem, which was even outside the bounds of what we did in this research. And of course, addressing that last mile problem will lead even to astronomical improvement. But what we did then was, what if we look at what the country was trying to do at the point of conducting this analysis? The country was trying to reorganize its vaccine supply chain. Okay, the reorganization is from this current system we have here, which is made up of 6 zonal hubs that serves the states and then the local counties. The country considered moving over, instead of 6 hubs, to just a 3-hub system. By the 3-hub system, it means vaccines come from abroad and they go to the regional hubs of the 3 hubs we have in this figure on the right-hand side. And from there, they go to the states. So what we've done, and is what the country was thinking of doing, is eliminating completely one of the echelons of the supply chain and trying to see what improvement in performance that will lead to. Guess what? Yes, the performance was actually improved. In fact, not only was the performance improved at 100% fill rate, we also found that the capacity that will be needed to achieve that 100% fill rate is not as much as if we had kept the 6 zonal hub location that we had before. Remember, if I go back 1 second, notice the 3 regions the country was splitted into. The choice of the regions was based on political considerations, purely politics, okay? Now, that did not consider population density, did not consider distances, which is where the next part of this talk is going to. Well, I told you that not only was the performance improved, the requirement of increase in capacity was actually not as much. with the redesigned system. It was a proposed redesign. This is what this graph shows, that if we keep the current system and want to improve the performance of the system, we need about 55% increase across board of storage capacity. However, if we redesign the system, eliminating one of the echelons of the supply chain, we need increased capacity, but not as much as if we had kept the current system. This is a very symbolic result for a country with limited wherewithal to actually expand vaccine supply chain capacities. Well, we thought about this problem and we said, where can we submit this paper? And we said, Health Affairs, the foremost health policy journal in the world. Are they gonna like this? Guess what? We submitted it. They were like, Dio, send us the entire manuscript. 2 review cycles later, were printed in Health Affairs, a foremost journal. From that point, I said, well, we have done the analysis based on what the politics of the country stipulated in terms of the reorganization. I now called on the senior design team I was allocated the year this was published, a year before, that was 2017. The senior design team was made up of Dorhash Bagai, Zachary Graybill, and Paula Vovertsky. I said, guys, I have this problem. The country has made decisions based on political considerations. Let us use our systems engineering tools to address the problem. They said, what problem, Professor Shittu? I said, well, number one, let's identify where the regional hubs should be. If we knew exogenously what number of regional hubs we want. They said, that's easy. We can just do a shortest path problem. I said, aha, now you are thinking. So step one, shortest path problem. And that shortest path problem minimize distance between states and the regional hubs, okay, subject to the choice of a link between any state and a proposed hub equal to 1, and the number of hubs exogenously given. In this case, we tried with 3 hubs, we tried with 4, we tried with 5, we tried with 6, and then we also bifurcated by saying that what if we intentionally include the national strategic cold storage, that's the central location in the country, as a hub, or we just let the model choose it's by itself based on the number of hubs we propose. And we allowed, so what the kids did was, or what the students, I say kids, I'm sorry, what the students did was they collected data of every state capital in Nigeria and the distance between every state capital, and they created a set covering problem that maps out what those distances are and chose where the optimal hubs should be if you are going to have 3, 4, 5, 6 hubs. This is the result of that analysis. The first result shows if there are going to be only 2 hubs, where should they be? That will minimize the distance of the states that that hub is going to serve. Those are the 2 locations in yellow. In the middle at the top graph is if you're going to have 3 hubs. What you see here is that the government choice of 3 hubs, which was based on politics, is actually a way completely different from what the optimal solution is telling us. If we are going to have 4 hubs, notice that those hubs at the top, the 3 top figures, we do not specifically use the central national strategic cold storage, which is in the center of the country. The lower 3, we impose the strategic cold storage. Say, okay, what if we want to keep it mandatorily as a hub, and then add additional hubs to that center hub? And this is the result, optimal result. Now, it's one thing to identify the hubs. It's another thing to now ask the question, well, the previous paper did nothing, but just talked about capacities. What about the cost of building the capacity? What about the cost of storage? What about the cost of the vaccines? This is where senior design students are just phenomenal. They ran off the roof, out of the building, scrounging for data on vaccines. By the time they were done at the end of the senior design, some of them were breathing vaccines. They know the cost, they know where they are, they know who makes it, they know the manufacturers, they know which countries the vaccines are lacking. To cut a long story short, we now minimize the total system cost based on the cost of the vaccine itself, the cost of storage, and the transportation cost, which is a function of distance between the hub and the state. We ran the models, and what do we find? Lo and behold, the government proposed no central tree structure has a very high distance of coverage, and the storage capacity is just moderate. That is sort of consistent with what we found in the earlier paper. Now, when you look at all the other combinations, all the way to the current system is the last bar on the right-hand side. It shows that not only is the distance high, the storage capacity is also high. That result right here exactly mimics what we had in our earlier paper in health affairs. And guess what? What the kids did while they graduated and they left for, their 1 year vacation, and, I graduated, I made it out of college. I sat down and cranked out the paper, which got published in Vaccine. That is the #1 vaccination journal in the world, made up of undergrad student research project. Anyway, to cut that long story short, we see what the cost of the system is, and based on this cost, we're able to make suggestions. Now, the suggestions are very clear. It's a data-intensive problem in an environment where data is hard to get. There's uncertainty in demand. There's so many moving parts in the model. The multi-level supply chain, based on the current design, the proposed redesign, we studied it intensively, minimize vaccines in the system, while at the same time maximize performance. And then the outcomes we found that yes, we can improve the storage infrastructure, no doubt about that, by increasing capacities. We found that. On the other hand, the reorganization of the existing systems can actually offer even bigger performance improvements, not only in terms of capacity expansions that is needed to be lower, but also in terms of cost. And there was a President Emergency Plan for AIDS Relief, which is a US initiative. They call it PEPFAR, okay, which is saying that can the private sector, can the public sector learn from how the private sector approaches and addresses these problems? Well, when we did all of that, we now say, what are the policy implications? Improving system performance requires treating each vaccine, because vaccines have their own DNAs. They are different. The population they serve is different. The conditions they are adopted in is different. So we have to study each vaccine within the entire network of the interdependence between vaccines. Immunization policymakers have to consider vaccine availability by type and region. And this problem, while it sounds like it's an African problem, it is a developing world problem. You find it in every developing country. Vaccine for COVID-19, yes, that is what we're all rushing for right now. Who's going to develop the first functioning and safe vaccine? A vaccine that is effective and safe. Who will develop that? That is only one part of the problem. The next problem, which not many people are thinking of, except maybe systems engineers and operations research folks are thinking about this problem. How do we get it to those that need it first? How do we get it to those at the front line, the elderly? What structure are we going to develop such that we do not over congest the existing supply chain for vaccines and resources? That is a major hurdle we have before us. Reducing hierarchical complexity of the supply chain will also improve performance. We just saw that, especially when you look at budget-constrained environments where the resources to massively invest in cold storage capacities are not there. So what you see in this project is we have recorded successes based on some of the suggestions that came from this project. Now, I have a short story to tell. When we did this project from funding provided by LMI. LMI is in Northern Virginia. Like I told you earlier, $50,000 for 1 year. Of course, LMI was so impressed with the outcome of this project that for the next 4 years, they funded us at $75,000 each. So over the course of about 3-4 years, we had received almost $300,000 from LMI. The point I'm making here is, while we executed this project for $50,000, Nigeria consulted with McKinsey. We all know McKinsey, right? for millions of dollars. McKinsey produced one of the most elegant reports you ever see. Very colorful, glossy. Guess what? They made exactly the same recommendation as we did in this project. And we did our project independent. We're not even aware that McKinsey was working on this project. I mean, in fact, in the review process, we got a hold of the McKinsey report and we sent to the editor of Health Affairs. And it was like, ooh, we said they funded that research for millions of dollars. And here we are, $50,000, the same report, same recommendation. My team was made up of Roger Miller, who used to be at LMI, is left LMI now, Melissa Anley, who is with US Navy, and Shanta Whitaker, who is now a vice president for health technology in some technology company here in Washington, D.C. These were the people I worked with. I'll be very happy to take your question. This was when I went to Nigeria to collect data at the National Primary Healthcare Development Agency. This guy on the phone, he just felt it was a cool thing to be on the phone while this guy from America is here to collect data. I mean, these are experiences that you just have to laugh and smile about. Those were the experiences we had on this project. I'll be happy to take any questions.
Thank you so much, Dayo. I hate that we're all muted and you can't get the wonderful applause that you would get if we were all together in person and hearing us laughing at your jokes and everything. Thank you, Adam. I see the glad hands. So I'm going to first turn to Renata, who's been managing the chat, to see if you would like to call out some specific questions. And then for the rest of the audience, feel free to go ahead and just put either a question mark or a C in the chat, and then we can unmute you to ask your questions.
Would you like me to read the questions or call on them to read their own?
For the sake of time today, why don't you just go ahead and read?
Okay. So Marissa has a question and she asked, have you seen disruptions to the supply chain in Nigeria, like drug trafficking and stealing?
Oh, yes. In fact, you know, one of the reasons which I didn't mention in this presentation, why the polio eradication initiative failed for a long time. One of the reasons was that there was the religious pushback, okay? The northerners, where much of the polio incidences occurred, they felt that vaccination is against Islam. They felt it's against their belief system. So for a long time, they pushed back. That was one problem. The other problem is, and I'm not proud to say this is a country where graft, when I say graft, I mean corruption, okay? Where corruption is significant. I mean, billions of dollars are pumped. The country takes World Bank loans, IMF loans to fight this problem. So yes, you're right. There are additional issues which, frankly, we may talk about them qualitatively, but quantifying them in models, you know, is not something that really flies with, you know, we are science people. We do analysis for the sake of, you know, the data we have. Now, of course, I mean, even look at the reorganization of the supply hubs. It was done purely based on political inclinations. Whereas when we did the science without considering the politics, we identified different locations than the ones that the government actually was suggesting. So your question is valid. In fact, when you look at human trafficking, which again is one of the maladies facing the country, we have, you know, young girls of 18, 19, even younger being, you know, pushed abroad into prostitution. And so these are, you know, these are very, very burning issues, especially in least developed countries where the wherewithal, I mean, we're talking about countries where, you know, the average daily expense per individual is less than $1. I mean, you know, there's a lot of story to tell about some of this environment, which is why I tend to spread the gospel that, look, I am talking as someone, I have been to probably 35 countries across the world. I've been to every continent. I was on the IPCC, Intergovernmental Panel on Climate Change. That took me around the whole world. So I can speak for the exceptionalism we have in this country. And that is something not many people are aware of. There's a lot going on here, you know. So your question is very valid. Within the context of a model, we might throw in additional constraints that capture some of the things you're talking about. But again, like we say in the IPCC, we want to be policy relevant, but not policy prescriptive.
Thank you. We have another question from Stuart, and he's wondering how a COVID-19 vaccine could affect vaccine storage in Nigeria and whether prior reorganization should make the distribution of the vaccine easier.
I'll tell you what will happen. If a COVID-19 should arrive today, other vaccines will suffer. That's just the bottom line. They are going to relegate whatever supply chain capacity, storage, whatever that exists right now for other vaccines, just to take care of COVID-19. Because that, you remember this project, the initial idea behind this project, the proposal we wrote for this project was to look at, hey, malaria vaccine is imminent. It's going to be developed in the next 2-3 years. How do we accommodate a new vaccine in an environment where the supply chain is already strained? How do we accommodate it? What we find with COVID-19, given its intensity and how, you know, the rate at which it's taking away lives, they will just relegate other vaccines, flood the system with COVID-19 vaccine, if that should arrive, and eventually some of the, you know, excitement we have today about eradicating polio completely, not having diphtheria repeating itself, some of those may actually come back in the near future. Again, these are things that I believe modelers can begin to look at, even in the US. I mean, if COVID-19 vaccine that is, efficacious and works and it doesn't come with any side effects should be developed today, the scramble calls for modelers to come up with optimal solutions on distribution patterns and routes, for example.
Yeah, I actually had a question kind of bouncing off of that. Do you think that your model could be like modified to fit like the distribution of vaccines in the US? Or do you think it's more specific to Nigeria?
I think the problems that we have in the developing country context, those problems are not here. I mean, look, I can even buy vaccines and keep in my own fridge, but we're talking about an environment where electricity comes in the middle of the night and it's a blip. It's gone. You understand? It barely cools the water in your fridge. So people have devised other means. In fact, the vaccines we're talking about today, research is also looking at developing some of those vaccines in powder form, so that when they get to the destination, they dissolve them in some liquid and the kids get to drink them. So I don't really see the same type of challenges, that we have in developing countries as we have in an advanced country like the US. But what I see here is more of what's, and I don't know how much modeling or modelers can address it. It's more of the political challenges that we have here than, logistical hurdles.
Yeah, thank you. And then we do have more questions. Do you see any opportunities to predict demand to further reduce the required capacity increase? And that was cost.
Yes. In fact, since we did this project, Gavi, the Global Alliance for Vaccination and Immunization, Gavi, the World Health Organization, the Global Eradication of Polio and Immunization, they call it GPEI, all those organizations, they've actually come up with what we call the dashboard system. So the dashboard system is one that is installed at many of the health facilities. And at the dashboard, you get to report your daily dosage that is still available. And that gets automatically transmitted to the central storage, the National Strategic Cold Storage, which is in Abuja, the center of the country. So that dashboard allows supply chain visibility. The managers of the vaccine supply chain in the country are able to tell. But then the dashboard, number one, requires a level of technical expertise, which is not prevalent in the country. Number two, to run the dashboard, you still need electricity, okay? Without electricity, you can't transmit any information. But the good news is that with the dashboard, there's been improvement in performance. But despite the improvement, the country still lags around 70–75% in terms of its fill rate of the needed vaccines at any given point in time. So yes, technology can help, but as you can see, there's hardly a technology these days that doesn't require electricity. And we still are in an environment where the idea of solar panels, some people even came with solar refrigerators. Those solar refrigerators, mostly imported from all these countries, they function for like a week or 2 weeks, they pack up, and the wherewithal to repair them is not there to fix those refrigerators. So people have been thinking of alternative strategies, like I mentioned, powdered vaccines dissolved in water, but then those are only available for specific types of infant, morbidities and whatever, but not for everyone. Some of them have to still come in cold form, from abroad and delivered. The problem is not supply getting to the country. The problem is from the point of entry all the way till it gets into the mouth of the kid. That is where the problem is. The supply chain from the point of entry to the final destination. That's where the problem. So I think that in terms of those challenges, it's just a convoluted problem, which is why the country is putting in a lot of resources to addressing the problem.
So Gaia, we're hitting 5:30, and I want to be respectful of everyone's time. But I'm so appreciative of this talk, and if you're willing to spend the day with us, the afternoon with us, and what started off as something that you probably didn't anticipate would be quite so timely at this particular moment. I want to thank you again for participating, and thank everybody for joining in and the great questions. And we'll be back next week with a panel from some of our alums who are going to be talking about their experiences working in the healthcare environment during the pandemic. And again, please feel free to bring your students and colleagues and to spread this. And we look forward to watching how your work unfolds in the coming years.
Thank you very much.
Energy stuff is important, but keep doing your healthcare work. It's great.
Thank you very much. I appreciate it.
Bring enough energy to certain parts of the world, the health problems will automatically get better. So
that's true.
Thank you again, and we really appreciate your time.
Thank you very much. Thank you, and enjoy the rest of the semester as well. Stay safe.